Hi, my name is Isa Smirstik. Support for this episode and the following message come from Audible, where you can get access to nearly 200,000 audiobooks. I recommend The Ghost in My Brain, How Concussion Stole My Life, and How the New Science of Brain Plasticity Helped Me Get It Back. This book needs no further explanation. This book or any other can be yours for free for 30 days if you sign up on audibletrial.com/brainwaves. That's audibletrial.com/brainwaves.
Fair warning, this episode features a discussion on death and brain death in ways that may sound insensitive to some listeners.
We will be talking about brain death as more of a legal term rather than a personal experience.
And while there may be jokes on the show, obviously death is a serious and grim event, and we hope you will not take offense with anything that is said.
Still, we hope you'll enjoy the show. Before we realized the true importance of the human brain and its role in consciousness, communication, behavior, and personality, before we knew all that, whenever the body would die, the brain would die. It all kind of happened together. There was no difference between cardiac death and brain death and kidney death. The heart would stop beating, the lungs would stop breathing, and eventually oxygen and the vital nutrients would not be transported into the nervous system. Once the heart or the lungs stopped, the brain stopped. At least that's what happened until the middle of the 20th century. Death was a total body experience until we learned how to artificially support failing organs, notably the heart and the lungs. Historically, artificial ventilation of the lungs has its roots maybe before the time of Christ.
And he went up and lay upon the child, and put his mouth upon his mouth, and the flesh of the child waxed warm.
That was an excerpt from the second book of Kings, where scholars maintain that Elisha resuscitated a child using positive pressure ventilation. Over 2,000 years later, in 1780, Chaussier invented the first commercialized device to apply positive pressure in surgical patients, a bag and mask mechanical ventilator, something we still use today. A negative pressure ventilation device wasn't available until 1838, when Scottish physician John Dalziel invented the tank ventilator. Imagine crouching inside of an airtight box, with what looks to be an accordion pumping air in and out of the box. These pressure changes would be so great that they would induce the expulsion of air from your lungs, followed by a negative pressure force that would eventually cause your chest wall to expand, allowing your lungs to draw in air. Sounds comfortable, right? Eventually, the modifications were made to this small box, and patients could lay down inside of it, with only their heads exposed. The use of such a ventilator was immediately obvious to many hospitals, given the polio outbreaks of the early 20th century. Boston Children's Hospital actually developed a multi-person ventilator that would have enough room for 4 patients for a single machine. Later, in 1947, Claude Beck would successfully defibrillate a human heart. So now, cardiac death could be prevented. However, the true genius responsible for the paradigm shift in death determination was Bjorn Ibsen, a Danish anesthetist who took the idea of volume-cycled ventilation in anesthetized surgical patients and applied it to those children who were suffering from polio. In 1952, during one of the worst polio epidemics of Copenhagen, nearly 3,000 cases over 2 months, Ibsen surgically placed a tracheostomy into a 12-year-old quadriplegic girl who was choking to death on her own secretions. After adjusting her sedation and monitoring the carbon dioxide and oxygen content from her respirations on the ventilator, he was ultimately able to bring back the natural color to her face and save her. At the height of this epidemic, 70 patients a day required continuous manual ventilation, which was usually performed by dental or medical students over 6 to 8 hour shifts. Although it consumed a lot of manpower, it was a tremendous success. The mortality rate fell from about 90% to 25% using this single intervention alone.
And that's when you take somebody who suffered some catastrophic event, you put them on a ventilator, and there were some people that you could maintain forever.
This is Mike Rubenstein, a neurologist you may recognize from being on our show before.
And then there were some people who basically all of a sudden, no matter what you did, within several months, they started to deteriorate and they would die. And so they said, well, there must be something here that tells us what's different about these people than those other people that we're able to maintain. And what it turned out to be was that these people were brain dead.
The popularity of artificial ventilation flourished after this point in history, and more indications and techniques for maintaining adequate oxygenation were discovered. By 1955, the first mass-produced ventilator, the Birdmark 7, was introduced. By the time that commercially produced lungs could be sold and utilized in hospitals, the brain could survive in the absence of intact lung function. You can imagine that once this approach was applied to patients who were comatose from disorders of the central nervous system, conditions like traumatic brain injury, encephalitis, or severe stroke or hemorrhage, that the usefulness of an artificial breathing apparatus created an unprecedented ethical dilemma. Physicians would now ask themselves, is this patient who's on a ventilator alive? Before we even delve into this, I just want to read something about the controversy of brain death. It's from the 2008 168-page paper, Controversies in the Determination of Death, by the President's Council on Bioethics, led by Dr. Edmund Pellegrino.
Chapter 2, Terminology. Although commonly used to identify the neurological standard for determining death, the term brain death is highly problematic. 3 difficulties in particular are noteworthy.
Just to interrupt real quick, there are going to be a lot of air quotes throughout the episode this week as we talk about death and brain death.
First, the term brain death implies that there is more than one kind of death. Second, the term brain death implies that death is a state of the cells and tissues constituting the brain. In fact, what is directly at issue is the living or dead status of the human individual, not the individual's brain. Third, death itself is not a diagnosis. That is, the phenomenon of death and the selection of the appropriate standard for determining it are not strictly medical or technical matters. Thus, any term chosen as a label for a medical diagnosis should not contain the word death. It is not death that is diagnosed, but rather a clinical state or condition made evident by certain ascertainable signs. Calling the condition of the patient who meets a set of diagnostic tests brain death begs the question of whether the condition does or does not warrant a determination that the patient has died.
But there is no perfect term for what we would call brain death. The authors acknowledge this. Maybe from a medical perspective, it makes sense for physicians and medical professionals to call it brain death because then at least you're acknowledging what organ system is affected and why a patient may be declared dead is because that organ system is the most vital for
But we don't say
functions.
heart dead.
We don't, but we say cardiopulmonary arrest, which is basically cardiopulmonary death. You can resuscitate the heart.
Well, it's not dead because the organism isn't dead. The idea of death is that it's an irreversible process. The organism cannot recover. There's no possible recovery from death.
What if people arrest, though?
They're not dead. Dead is the point of no return. Death is when you have reached the point where no longer what technology or what you do, you cannot revive the organism.
I think that brain death remains a concept that's surrounded by confusion.
This is Dr. Joshua Levine, who's also joining us today on the segment.
Not only among the lay public, but also among medical professionals. And I think it is a difficult concept to understand when someone sees a loved one with a beating heart who's warm and are told that we think the patient's dead. That can be confusing. Maybe some of that has to do with the term brain death, because that very term sort of implies that it's something other than death.
Dr. Levine is one of the faculty members where I work who's responsible for updating and for maintaining our institution's policy on the determination of brain death.
Somehow I found myself being asked to be the rewriter, and ever since then I've been the one who's rewritten or revised our policy.
He inherited this responsibility after expressing several concerns with the prior version of the policy to hospital leadership.
One of the concerns I had was about the level of training of those who were permitted to do the exams and declare death. My view is that this is one of the few protocols or procedures in medicine where there's really no room for error 100% of the time. And ideally, you want the most trained people making that determination and not the least trained people. And so that was one of the issues.
So Dr. Levine took up the reins, and he's been one of the neurocritical care physicians responsible for how we diagnose death. Death as a diagnosis is already controversial, but really it is a state of the body that requires an assessment of the body and an interpretation of that assessment. And I don't see how that's any different between what we do when we as medical professionals make a diagnosis. And with any diagnosis, one can reach the answer in several ways.
People should understand that there are two ways of dying. One is that the function of the heart stops, and the other is that the function of the brain stops, but both should just be called death.
And these two ways of diagnosing death are the ways consistent with the Uniform Determination of Death Act, a 1981 statute that was passed in the U.S. But how do we define death? In the neurologic sense, I mean. What is our current standard today?
So there are 2 or 3 major components of brain death. And I say 2 or 3 because one of them is really a part of the other. So classically, the 3 cardinal components of brain death are coma, absence of brainstem reflexes, and apnea. But apnea is really a brainstem reflex, so whether you call it 2 or 3, it doesn't matter.
And these 3 criteria, coma, absence of brainstem activity, and apnea, they really haven't changed much in the 50 or 60 years since this topic emerged in the medical literature. So let's go back to the beginning and get into the minds of the physicians at the time who were responsible for developing this social medical construct. It's 1959. We're in France. Patients with severe neurologic injuries are being placed on mechanical ventilators, and they are not waking up. In fact, some of them begin to suffer irreversible multi-organ failure in spite of all the artificial life support that's available. They are still dying, and it's unclear why. But 2 physicians, Pierre Molleret and Maurice Goulon, described the neurologic exam findings of 23 patients who eventually progressed to multi-organ failure and then death, and they called this physical state before death coma dépassé.
So what is coma dépassé?
So coma dépassé was what Molleret and I basically described in 1959 in a paper, and it was that, there were these patients that they had that looked no different than other patients, but could not be maintained forever, and it was these patients that were beyond coma. So if you had patients that were in coma, you could keep those people on a ventilator and you could continue maintaining them for indefinite periods of time, but there were these other patients that looked to be in coma. They kind of clinically looked no different, though lacking brainstem reflexes. Those patients would suddenly deteriorate after several months and die. And so those patients were the ones that they said were this beyond coma. And so the question was, what is beyond coma? We now know the clinical entity of beyond coma is essentially being brain dead.
Much of the movement to codify the term brain death originated from Massachusetts General Hospital in Boston. In 1963, Robert Schwab proposed a triad of criteria for, quote, death in spite of cardiac action. These included, first, fixed and dilated pupils, no elicitable reflexes, and no spontaneous movements. Second, apnea. And third, an isoelectric EEG. Together, these exam and diagnostic tests confirmed the absence of much of brainstem and cortical function that we could test for at the time. They sort of set the stage for precisely what neurologic abnormalities were needed to determine that the patient had a non-survivable brain injury, which for the most part meant death of the brain and the brainstem.
If they don't have brain death, essentially by what we've used as that definition, then you should be able to maintain somebody in a persistent vegetative state or in some other state for a long, long period of time. You can 10, 15 years, they have some lifespan. Whereas people that have had death of their brainstem in that portion, those people can only survive a period of months before they start to have failure of other organ systems.
But if the patient lost cortical function and had intact brainstem activity, he or she might be classified into what we think of today as a coma or a persistent vegetative state, often requiring medical interventions and other artificial measures to preserve life. And at the same time that human organs could now be artificially supported, surgeons thought, why not simply replace these organs? Maybe it seems ironic, but the concept of brain death co-evolved with the practice of organ transplantation.
I think there were two primary drivers for the concept of brain death. The first was just the advances in critical care that allowed us to preserve organ function for much longer periods of time, even after the brain had ceased to function. So that was the first driver. The second was absolutely the advent of transplant technology. And those two together set up circumstances that were ripe for the concept of brain death. I think that brain death is really a social construct. It's not necessarily something that has, it's not sort of a firm biological diagnosis. It was really a social construct that was clearly driven by advances in critical care and by organ transplantation.
It was happening at the same time. So basically what people realized was that, first was this clinical entity of, quote, brain death or neurologic determination of death. That was going on at the same time as we were discovering organ transplantation. And so the idea was that you can only take organs from a dead person.
It became obvious to surgeons in the mid-20th century that the organs harvested from living donors were more viable than the organs that were obtained from deceased donors. So keeping that organ functioning, keeping it perfused in a living body, was ideal.
The initial organs that were transplanted were, in 1954, was the first successful live kidney transplant between identical twins. And so we have that. And then in the 1960s, the early 60s, and 62, the first successful cadaveric kidney transplant. And then in 63, the first successful lung and liver transplant. And then in 1967 was when Christian Barnard in South Africa performed the first successful cardiac transplant.
The problem was, now that people could be placed on artificial life support, even if they otherwise would have died, when could a surgeon take a liver or a lung from a patient whose heart was still beating or whose lungs were still breathing?
At the same time, there was a huge ethical issue because there was obviously, it was a conflict of interest if you have surgeons who are looking for organs to transplant and the same people are taking care of people who are, quote, brain dead, then there's an issue about you have to separate those two things.
I'm not sure whether I would call it a conflict of interest. I think certainly it was motivated by transplantation of organs, but I'm not sure that I view it as a conflict of interest.
Regardless of what you believe and whether there may or may not have been a conflict of interest among these surgeons, at the dawn of organ transplantation, there was no consensus among physicians as to when a patient may be dead, in spite of a beating heart and lungs being mechanically ventilated. Surgeons needed something more concrete in order to justify organ harvesting from people whose bodies were no more than vessels for organ viability. Adding on to Robert Schwab's original triad of death in spite of cardiac action, the Belgian surgeon Guy Alexander required that 5 neurologic criteria be used prior to organ harvesting. First, complete bilateral mydriasis, blown pupils. Second, absence of reflexes in the brainstem. Third, complete absence of spontaneous respiration or apnea. Fourth, falling blood pressure necessitating increasing amounts of vasopressive drugs. And 5, an isoelectric EEG. The EEG, as you'll see, is going to become a theme here, just like our air quotes. But this was hardly a standard set of criteria, even in Belgium at the time, much less in the United States. So, in Boston, at Massachusetts General Hospital, Henry Beecher, the chair of anesthesiology, called upon the dean of the Harvard Medical School, Robert Ebert, to discuss the ethical problems created by the hopelessly unconscious patient, as they phrased it. In 1968, they published a consensus statement titled, A Definition of Irreversible Coma.
The 1968 report of the Ad Hoc Committee was important for many reasons. First, it emerged out of a growing need to identify irreversible injury regardless of the advances made in critical care and resuscitative medicine. Also, we needed to clarify which patients could be organ donors now that they were officially declared dead.
This is exactly what Dr. Levine mentioned earlier.
The Harvard report also required that irreversible coma be confirmed on a second exam 24 hours later.
The first implementation of a staged or a repeat neurologic exam.
Before the Harvard report, death was determined only by the absence of a pulse. So the authors created a new term, irreversible coma, which would be a new criterion for death. And to be classified as having irreversible coma, a patient had to meet 4 criteria. No response to external stimuli, no spontaneous movements or breathing, no reflexes, and an isoelectric EEG.
And while it was the most influential paper on the topic, and is still one of the most widely referenced, it was not without fault. In a way, the recommendations in this paper almost made it too easy to declare somebody, quote, brain dead. The authors of this paper were ignoring confounders.
For example, extreme hypothermia or barbiturate intoxication can mimic brain death. Paralytic medications and medications that dilate the pupils that are often given together, for example, during a code.
Then there was the U.S. collaborative study, which defined death as only cerebral death. This paper was published in 1976 based on a cohort of 503 patients. The patients had to be comatose and apneic to be enrolled, and although it was not perfect either, some of the major points that we can take away from this investigation was that the neurologic exam in itself may not be sufficiently sensitive to determine brain death, and that an ancillary test would be needed. Now, I'll tell you right now, even though we're going to get into it more next week, the latest AAN guidelines do not require ancillary testing to confirm brain death, only the neurologic exam. That being said, these ancillary tests are going to be extremely helpful, as we'll discuss in a moment. Another thing that the U.S. collaborative study did add to our understanding of brain death was that mimickers of brain death had to be excluded for the diagnosis to be made. Despite each of these advances, the concept of brain death, or death by neurologic criteria, or whatever other term you want to give it, it can still be quite vague, even among medical professionals, as Dr. Levine mentioned. In its essence, almost regardless of where you practice in the U.S., the determination of brain death relies on 2 major stipulations: the absence of brainstem function and the absence of cerebral function. But there's more to the determination of brain death than just doing a neurologic exam. Declaring somebody dead is not so simple as making sure that the brainstem is not functioning and that the patient's in a coma. And we're going to dive a little deeper into this next week when we move on to the shortcomings of the brain death assessment, so stay tuned for that next week. I want to thank Drs. Joshua Levine and Mike Rubenstein for helping out with the episode this week. You'll hear more from them next Thursday as we continue our 2-part talk on brain death. The episode this week was produced by me, Jim Siegler. Music was courtesy of Chris Zabriskie, Damiano Baldoni, Josh Woodward, and Julie Maxwell. We are grateful for our many supporters, including Audible and also NatureBox, Snacking Made Simple. Please check out our blog at brainwaves.me for great deals you can get on all of our BrainWaves podcast affiliates. That's all we've got this week. I'm Jim Siegler for BrainWaves, and I'll talk to you next Thursday.